Welcome to this fourth video from our June 2023 symposium, The First Line of Defense. The idea that schools in fact offer the elements of a first line of defense that can mitigate the impacts of stress and anxiety is also an important foundational component of the much broader overhaul of conditions needed in American communities. In this presentation, Our Kids, Our Country, Our Future, Dr. Wayne Jonas presents significant emerging approaches for such comprehensive community health and well-being goals that also build on reimagining existing public and private sector infrastructures to support them. Wayne has been a supporter of this project since we got underway, and it gives me great pleasure to introduce him to give his views of the first line of defense, how it can lead into our country's well-being as a whole. Wayne, thanks for joining us.
Well, thank you, Taylor. Thank you for all you do and what you've done for so long. And thank you for inviting me to be part of this really special seminar and presentation. Can you hear me all right? Is that everybody hear me?
I can hear you. Sounds good.
Great. And I just ask you to advance the slides. Is that it?
Yes, please.
Okay, great. I want to sort of take a 30,000, or if you will, maybe a 300,000 foot view here to talk about what do we mean by the first line of defense and what are the dimensions of the first line, because I think we need multiple lines if we're ever going to get to the first line and maintain both our freedom in the country, our flourishing, and our future. Some of this you've heard about already, but I want to scroll back and just give you a big snapshot of what healthcare does. And ask you, after you hear this, whether you think we ought to have more. So we dump a lot of money into healthcare. We're absolutely first in spending, almost double any other country. And yet the health outcomes by almost any measure, WHO is one of them, is about 37th in the world, and close to last for many of them in comparable rich countries, peer countries. We're going to spend 20% of our gross national product by 2031, possibly even before that. And that growing expense is going to continue to drive the gap in disparities between those who can afford it and those that cannot, the haves and the have-nots. There are growing mental health problems, which you've already heard a taste of, especially among youth, which means it's going to continue into the future. And there's widespread dissatisfaction. I can't heard anybody who's gone in to get their average healthcare checkup who's really liked the system. And those who work in the system also are dissatisfied with increasing burnout, decreasing well-being, and almost 20% during the last 2 years leaving the whole profession. So pretty soon, even if you can afford it, you won't be able to find it. Finally, the future of this system does not look bright because the children's health is declining. And this isn't only in mental health. It's in physical fitness, it's in obesity, it's in the early development of chronic diseases, and so our future is at stake. Our current healthcare system I call a triple oxymoron. It's not delivering health, it isn't caring very much, and it is definitely not a system. We need some major reform if it's going to get back to producing health in the nation. Okay, next slide, please. We also know why this is happening. Clear data shows that even if everyone had universal access to platinum level health coverage, it would only move the actual health in the nation by about 15 to 20%. And that's because health doesn't come from healthcare as we currently deliver it. So again, I ask you, do you want more of that? The money that we're spending in this is not producing health because health comes mostly from behavioral and lifestyle issues. You've heard examples of that, and the social and economic disparities that are increasing in our country, and increasingly by the physical environment that we live in. And so if we want to produce health, we need to invest in the underlying determinants of health as seen in this circle, and not just in more health care, but we do need to align health care so that it's producing health. Next slide, please. Well, there are certain organizations, some of them pretty large in the country, that have defined populations and control over those populations, that have seen this kind of writing on the wall and are trying to take things into their own hands. The first one, as is often the case, is the Department of Defense, because they recognized, over 20 years ago, that the growing health problems among the youth in the country, some of which you've now seen in the mental health area, but they 10 years ago were more concerned about obesity and physical fitness, was not going to allow the country to defend itself should we need to actually do that. Because we don't have a cadre of folks that could defend the country. They're not fit, they're overweight, and they have mental health and drug use issues that preclude them from functioning as the first line of defense, that is national defense. So that's the first dimension of the first line of defense, is that our youth are not going to be feeding the defense of the country should we need that. And I don't need to tell this audience that there are growing rumblings over in Russia and China and other places that may make that a requirement, hopefully, God forbid. The VA, those who have been in the military, has a defined population and has recognized that they need to change what they're doing if they actually want to produce health and flourishing in their population. And I was glad to see that we had Ben Klinger, who runs this program, who runs this program for the VA called the Veterans Whole Health Program, which has shifted to a holistic approach to help veterans address the underlying determinants of their own health and not just simply provide health care. Next slide, please. In healthcare, especially those in public health and primary health care, there's a growing recognition that we need radical changes if healthcare is actually going to get back on board and begin to produce health. Here is a report that came out a couple of years ago from the National Academy of Sciences, Engineering, and Medicine called Implementing High Quality Health. And it was defining high quality primary health as whole person care that is equitable and integrated, accessible. And if you look down a little bit further in the definition, it addresses needs across settings. So it's not just isolated within a clinic. It maintains sustained relationships with patients, families, and communities. I dare say that has to be the schools and embedded in the community. And the payment models we need to pay for teams, not just doctors, to deliver those health services. Unfortunately, if most of the doctors were trained like I was, we don't know how to work in those teams, and we don't work much in the community. We work in the clinic, and we wait for somebody to come in who has sickness, and as Dr. Rosen said, don't really address the underlying causes. Next slide, please. To try to remedy this situation, my foundation, in partnership with many, many others, has created tools to try to help the conversation that goes on within the healthcare encounter to change, and specifically focus on what matters for creating health of the individual in front of you. We call this the Hope Note Toolkit. That stands for Healing-Oriented Practices and Environments. And it takes the body and the external aspects, the behavior and lifestyle factors, the social and emotional components, and the spiritual and mental aspects of a human being, and it asks those questions. It starts with the center, the spiritual and mental components. Instead of saying, what's the matter with you and how can I diagnose, code you and pay and get it paid for, what matters to you? Why do you live for? Why do you want health? And then help you gain that through your own health promoting behaviors. Next slide, please. There is an entire set of resources within this toolkit, from an encounter form, the personal health inventory adapted from the VA, an integrative health visit instruction, and a whole set of personalized resources for creating a personalized healing plan and address the underlying factors that actually produce health including mental health and the social determinants. We've recently taken that and with a group of oncology leaders adapted these tools for the application in cancer care also. Next slide. For those of you who are interested in learning this, we tested this within a network of clinics around the country, refined them, and then helped develop those tools and put them into not only a publication, which came out a few months ago in the Annals of Family Medicine that describes and makes all the tools accessible, but also worked with Tufts University Education Department to create a continuing medical education program. This is 15 hours of free CME that you and healthcare providers and your systems can take to learn actually how to do whole person care and how to embed it. There's the link. It's called integrativehealthcme.org, and it is free because of a grant from the Samueli Foundation. Next slide. Most of these clinics told us it's the same thing, however. It was a challenge to do whole person care if the system itself didn't redesign itself. And here's an example of that redesign published in JAMA Health Forum. It was originally developed by the Cover Commission, looking at the whole health program and the mental health programs within the VA, but then it was changed to be able to address healthcare anywhere in the country using something called the two-circle model of whole person care. It has the normal treatment paradigm on the right-hand side and the medical services that can be accessed to that. But it adds to that the whole person care, the health promoting factors on the left-hand side, the so-called recovery services, using tools and resources like the Hope Note and a personal health plan. It is person-centered, not patient-centered. It is relationship-based, which has been proven over and over again to be a superior system for health delivery in populations. It is recovery-focused, not simply maintaining or palliating, and it is paid for by value-based payments. In other words, it's paid to get good outcomes, not just deliver services. This model has recently been picked up by another National Academy of Medicine report and was published a couple months ago, looking at the VA, the whole health program, but then looking at how that could be scaled and extended to the nation as a whole. I urge you to take a look at that. It's called Achieving Whole Health, and there's a picture of it on the right-hand side. It's free from the National Academy. Next slide, please. However, none of this will work. The Defense Department by itself cannot create health in the nation. The Veterans Administration cannot create health in the nation. So the first line of defense by itself will not be adequate. The second line of defense, that is changing the healthcare system, will also not be adequate. And here's an example of what's happened even with all of these efforts in the last 2 years. We have had not only rising healthcare costs, but we have had a precipitous decline in our life expectancy. Almost a 2-year decline in life expectancy has occurred, 3 to 4 times that drop in people of color. This is not going on around other places in the world. In fact, comparable peer countries that have the same wealth and types of systems that the United States have only had a half of a year of drop of life expectancy, mostly due to the epidemic, COVID itself, but not due to the other factors. We've seen also, unfortunately, our future slipping away because the decline in life expectancy is also occurring in our children. The system as a whole, the community as a whole, is not working. Next slide. We know what's needed for human flourishing. In fact, over 50 years ago, a model of prosperity and human flourishing was developed by Abraham Maslow, which has stood the test of time. It was called Maslow's hierarchy of human needs. It put the basic needs at the bottom, the physiological needs like food, water, warmth, shelter, the safety needs, the belonging needs, and the self-esteem needs, the so-called psychological needs. And then he said, after you have those, then you can achieve self-esteem needs. At the end of his life, he added one more on the top, and that was self-transcendence. So it went all the way from the physical needs to the spiritual needs. And these were the core components of what a human being needed. Now, Maslow made one mistake. It is not a hierarchy. Everybody needs all of these factors. And so to care for the whole person, we've reorganized the hierarchy into a circle that you see on the right, and defined a whole person as someone with a spiritual and mental body in the center, the social and emotional components, the behavioral and lifestyle aspects, and the physical and external body. And in fact, taking care of the whole person means taking care of all these factors, not just one at a time. Next slide, please. We've heard of going upstream, and we had an excellent illustration of that by Dr. Rosen, talking about the social determinants of health. But I'd like to talk to you about a different upstream, and that's upstream in terms of age. We know, for example, that those who have Maslow's hierarchy of needs get their human potential enhanced. That's the top curve in this graphic. They're productive, they have social contribution, they're flourishing, and the economy flourishes with it. Those who do not have those needs addressed and are not addressed then have lost potential and an increasing need for support and medical care. That gap over on the right-hand side is in fact what the return on investment would be in our country, the economic prosperity, if we were to close that gap so that everybody had the top of the curve hierarchy of Maslow's needs. Closing that gap is also the equity gap. And so if we close that, we would have increased equity. Notice one thing about this graphic that I think is important for where we need to focus. If you address these needs early on in birth to childhood and even pre-birth, within the first 3 to 5 years, the flourishing that occurs there builds on itself. And so people are much more likely to be on the top of this than they are at the bottom. And so you get much more bang for your buck, the biggest return for investment if you go to the youth, if you go to the early childhood areas. Let me show you one example with the next slide. This was provided by Dr. Kathy Bossi. It is the Center for Economic Human Development. It's called the Heckman equation, and it's just one illustration of a program that was focused on improving support and productivity by early childhood support and education. This was 1 to 3 years, preschool in this area. And they showed over a period of 30 years, a huge increase in productivity, higher income, better health, more family investment, upward mobility. It had a 2-generation effect because then the mothers also improved in that area. The total benefit, the annual return on the investment per year was almost 14%. I don't know about you, but if I got a 14% investment on my savings account, that would be awfully good. The ROI, the benefit to cost ratio, was 7.3, meaning you got $7 for every single dollar that was invested in this program. And there are multiple other programs showing this type of upstream will produce economic prosperity, the first line of defense, if you will, and that is economic prosperity and mobility for everyone. Next slide, please. To do this, we are going to have to engage the schools, it is true. And here's an example of the CDC Healthy Schools program and how Whole Health ED and the whole community and whole child programs dovetail and feed that model of school health and school well-being. But as we've heard and as I've illustrated in this talk, simply focusing on the schools by itself will not be sufficient. What we need is a whole community approach that incorporates the schools, healthcare, and special populations, as well as the community. Next slide, please. In a month, actually less than a month, July 17th, I just found out about an hour ago, another National Academy of Medicine report is going to come out. But this one, called Valuing America's Health, is going to focus on the economic shifts, the money changes that have to occur if we're going to produce human well-being and flourishing in the country. It has a lot of very specific recommendations drawn from quite a bit of data. Here's two examples of two books that just have come out in the last few months. One, How Poverty is Sustained by Our Policies in America on their left-hand side, and one of the members of the committee on how it can be resolved, The Fifth Freedom, in the book on the right-hand side by David Erickson of the New York Fed. One of their recommendations is going to be creating community well-being coalitions. Now, these already exist, but what they're suggesting is that money is taken out of areas that do not produce national health and flourishing and be put into local communities, governed by local communities, and that they draw from local resources and capture local metrics guided by assistance from the federal government, but not necessarily paid for by the federal government. Stay tuned for that as it comes out next month. Next slide. Here's an example from Dr. Kathy Basie, a former director of the Dow Chemical Company, who then, when she retired, went into the Michigan community and created a community well-being coalition that linked the national policy efforts with the local policy efforts. It focused on things that work: the investments in vital conditions within the community upstream in the sense of early childhood investments within the community, and then tracking outcomes to make sure that the Community Wellbeing Index locally was in fact moving forward, as was social mobility. Next slide. Recently, a new organization, the Cornerstone Collaboration, put together by Dr. Tracy Gaudette, who used to run the VA Whole Health Program, has started to map the characteristics of these community coalitions in order to understand what's happening out there and how to advance them. Next slide. This mapping project will hopefully create a landscape of community well-being coalitions that are out there, of which there are many, convene leaders from them to explore synergies, create ongoing communities of practice, and then share those learnings that are occurring in those living laboratories, and then create a network of community well-being coalitions. This will create a ripe environment for the federal government to be able to facilitate that without paying for all of it, because the resources for these coalitions come locally. What's needed is support to create an infrastructure through an extension-like service. Next slide. An extension service, a community well-being extension service, similar to the agricultural extension service, one of the most highly successful government programs ever created in the country, was proposed several years ago by the Samueli Institute. It proposed creating support and facilitation services in every major population around the country, helping them to create their own community well-being indexes that then could be rolled up to a national well-being index and tracked right alongside the GDP, facilitating cross-resident and cross-sector community well-being councils, and in that then support that identified and tracked their own well-being as needed locally. Now, that program, a federal program, has been picked up by an organization of these community coalitions called We in the World. There's the website, and they're doing this from the bottom up. I believe there's readiness now for a federal act to actually catalyze this and let it catch on fire, an escape fire, if you will, to quote Don Berwick. Next slide. So, after the report comes out, I'm looking for folks who would like to support a Well-Being in the Nation Act. Senator Harkin was in the Senate. I wouldn't be surprised if this is something he took leadership on. It's modeled after the Agricultural Extension Service, and it would create a network of well-being extension services that could facilitate a pathway to whole person care to address not only what the Defense Department needs for freedom, what the country needs for economic prosperity, and flourishing, but most importantly, the final first defense, which I think is what Taylor meant by this title, Flourishing Children, which is our future. Thank you very much.
Wayne, thank you so much for this expansive view of the world in which we're moving, and which a lot of us are working on different threads.
Thank you for watching. Please be sure to check out the other videos from our First Line of Defense Symposium of June 2023, as well as the links to materials related to this video. See the links in the description below.